So, good afternoon. This is week 4. We are going to discuss today week 3, which was on nutrition of preterm and small babies. And we learned in that week, last week, about why we need to give mother's milk to the baby. And if baby is not able to take direct breastfeeding, how do you express the milk? And the expressed milk can be given with the help of a orogastric tube, which has to be measured and put at the right place. Or how do you shift from orogastric tube feeding to palate feeding or a spoon feeding and then to direct breastfeeding? So counseling is a very important part. And we know mother's milk is the best milk for the baby. In addition, in this week 3, we also learned how do you record the weight of the baby? How do you record the head circumference, length? And how do you plot that on the growth charts? So I thank week 3 faculty members. All of them took nearly 500 questions on week 3, which were common questions which were addressed. And I'm so happy that we have from week 3 faculty today Dr. Shrishti. She is going to make a presentation of what we learned on week 3. And we have Cecilia who has joined, Meena Joshi who has joined. In addition, I have Principal Pratima who is running the entire show of e-course on the Telegram app with me. So over to Shrishti for making a small presentation, and then we'll take common questions. Over to you, Shrishti.
Thank you, sir. I'll just start sharing my slides. So, as part of Team 3, which comprises of Sister Susie Sarazon, Sister Lewis, Dr. Ravi Sachan, Sister Cecilia, Sister Bobby, and myself, I would like to thank you all for your active participation in the nutrition module. So the important objectives of this package were to understand the importance of providing optimal nutrition, different methods of providing enteral feeding, best evidence-based nutrition practices, how to monitor growth, and how to use quality improvement methods so as to improve outcomes related to nutrition. So the goal of nutrition is to achieve the postnatal growth at the same rate at which a fetus would have the growth in the intrauterine period. So optimal nutrition is very important, not only to improve the short-term outcomes like decrease in the incidence of retinopathy or prematurity, improving bone growth, but also for improving longer outcomes like better neurodevelopmental outcomes. As far as possible, mother's own milk, and mother's own milk. For all practical purposes, there is no contraindication to breastfeeding or to express breast milk. Mother's own milk is tailor-made for your own baby. It decreases the incidence of sepsis, NSC, ROP, decreases the duration of hospital stay, and leads to better neurodevelopmental outcomes. So if the mother has HIV, TB, TORCH, COVID-19 infection, please continue breastfeeding. You don't have to stop breastfeeding. So in case mother's own milk is not available, the second best option is to provide pasteurized Zono human milk followed by preterm formula. But please be sure that these are not supposed to replace the mother's own milk. All efforts have to continue so as to increase the availability of mother's own milk. So in babies who are less than 1500 grams, you have to start with 80 ml per kg per day. In babies less than 1500 grams, you have to start with 80 ml per kg per day. And in babies more than 1500 grams, you start with 60 ml per kg per day of feeds with a daily increment of 15 to 20 ml per kg. And feeds have to be given every 2 to 3 hours. The mode of feeding depends upon the weight of the baby, the gestation of the baby, and the hemodynamical stability of the baby. So, as per the requirement for a preterm baby requires 110 to 135 kilocalories of energy per day and 3.5 to 4.5 grams of protein per day. So, whereas in term baby, the mother's own milk is sufficient to provide all the nutrition to her baby. A low birth weight baby needs extra supplement to meet the higher metabolic demands, like in the form of protein, energy, calcium, phosphorus, trace elements, and the supplementation has to be continued till 2 kg or 40 weeks, whichever is earlier. So supplements can be given in the form of individual nutrients. These individual nutrients, as we had already discussed, they have to be mixed in the milk. The reason being that they are very small in amount. If we just give them individually, they'll stick to the orogastric tube. So they have to be mixed in the milk. And however, while mixing, we have to be sure that they have to be mixed at different times so as to avoid hyperosmolarity. The other method of supplementation is giving the human milk fortifier. As the word suggests, human milk fortifier has to be added only in the human milk, that is in the mother's own milk or in the donor human milk at the rate of 1 gram per 25 ml, and it has to be given only if the baby is not able to gain weight despite being on full feed. So VLBW, that is a very low birth weight baby, has to be started on calcium, phosphorus, multivitamins, and vitamin D and iron. Of these, iron and vitamin D have to be continued till 1 year of age, whereas a low birth weight baby has to be started on vitamin D and iron only, and they have to be continued till the baby is 1 year of age. Now, how much feed to be started? As far as possible, start with full enteral feeds from day 1 itself. This will prevent prolonged IV access and thereby reduce the incidence of late onset sepsis, improve postnatal growth, and bring about gut maturation. However, in the following conditions, that is, if the baby's weight is less than 1000 grams, gestation is less than 29 weeks, if the baby has shock requiring inotropes, has severe asphyxia, has active seizures, obvious abdominal distension, or any surgical condition, in these following conditions, we will not be able to start on full enteral feeding by day 1. However, the more the baby is devoid of enteral feeds, the more the baby is at risk of having gut mucosal atrophy, impaired growth, and having diminished gut motility. So please start enteral feeding as soon as the baby becomes hemodynamically stable. In all these conditions which I just showed you, if the baby becomes, as soon as the baby is stable, you have to start with minimal enteral nutrition. So what is minimal enteral nutrition? It is giving feeds at the rate of 10 to 20 ml per kg per day. This feed preserves the gut maturity, helps in attaining full feeds earlier, and also helps in improved weight gain. So coming to monitoring the feed tolerance, the routine pre-feed aspiration is not recommended. It is only to be done in cases of abdominal distension. And in such cases, if the aspirate is more than 25% or it is more than 5 ml, please withhold only 1 to 2 feeds and again reassess the baby. Always rule out local causes for vomiting. Don't ascribe every vomiting that it is because of feed intolerance. The causes of vomiting can range from a very simple cause like malposition of OT tube, hypothermia, electrolyte imbalance, and CPAP valley to dangerous causes like sepsis and NEC. So what are the danger signs? So, sorry, what are the danger signs? Are highly prone to extrauterine growth retardation. Therefore, growth monitoring is very essential. We have to weekly plot the weight, length, and the head circumference using Fenton's or Ehrecron's chart. The targets are having a weight gain of 15 to 20 gram per kg per day till the baby is 2 grams of till the baby is 2 kg, having a length gain of 1 centimeter per week, and having a head circumference gain of 0.7 centimeter per week. Now coming to strategies to optimize preterm feeding. Dear friends, we should all have a written feeding policy for our NICU. We should have an early and frequent expression along with dedicated counseling. The counseling should address all. It should be in the form of GALPAC. You should greet, ask, listen, praise, advise, and check counseling. The counseling session should be please talk to the mother. The counseling should start both in the antenatal and the postnatal period, and you should motivate the mother to provide milk from day 1 itself. Involve family in the care of the baby. Perform non-nutritive suckling as soon as the baby is hemodynamically stable, and perform KMC. So last but not the least, coming to few of the quality indicators which you can see so as to monitor feeding policies in your department. You can the following are the quality indicators, that is the percentage of low birth weight babies who were started on enteral feeding at birth, percentage of low birth weight babies who are started on full enteral feeds at birth, percentage of babies who are on exclusive breastfeeding at the time of discharge, daily usage of mother's own milk in the neonatal unit, time to reach birth weight, duration of hospital stay. So the take home message is optimal nutrition is essential for better short and long term outcomes. Enteral feeding is best and free of all complications. Early initiation is better, and mother's own milk should be the first choice. Monitoring and growth and regular follow-up is required in all preterm units. Thank you.
The faculty who are logged in, before I ask few questions to faculty, let me ask Dr. Lallan. Lallan, you have been seeing how the nurses are interacting on the Telegram app. Would you like to speak few words on that? Dr. Lallan? Dr. Lallan is Secretary of National Neonatal Forum of India. Lallan, over to you.
Hello.
Thank
you, sir.
Yeah, we can hear you. You put your video on.
Thank you, sir. It was a wonderful session. I have been watching it very closely, and in fact, we have learning so many things from the nurses. Day by day, we are learning many things. So I must congratulate Anu and Pratima. Under your guidance, it was really a wonderful and successful program, sir. And for this week's faculty, I must thank Dr. Ravi, Dr. Mary, Dr. Baby, and Dr. and Lebis. We have learned so many things, sir, from nurses only. And this program is going to be hit, and we have to again start the same program. Thank you, sir. Thank you very much.
For your kind words. So, as Dr. Lallan is saying, I think learning never ends. You learn from a lot of people who are there in the front line, like all the nurses who are working in different SNCUs and NICUs. Many good practices may be happening in one hospital, the other hospital can start doing those practices. So it is a mutual learning, which is collaborative learning. And by this, India can make a real rapid progress in making sure that our small and sick preterm babies are getting quality care, their outcomes are better, their morbidity is going to be less, and even mortality is going to reduce. And while they grow, malnutrition is not going to be a problem. They will not be stunted. So it will be a intact survival with thriving well. We are contributing to the community. Now let me ask a question to Meena Joshi. Meena Joshi, question for you. Are you around? Put your video on. Meena? So the question for you in the chat box is, number one, how many times the mother should express the milk if her baby is small and the baby is very sick? Baby can't be given large amount of milk, but still you want the mother to express milk. How many times she should express?
Actually, she should express 6 to 7 times. The main thing is that we should not give more than 5 hours gap in between expression, because then there will be no stimulus, and we should not give too much stimulus like too early. So it should be like she can express around 4 hourly, at least 4 hourly, and tell her to rest in the night. Like night sleep, we know that the prolactin is more secreted during night, but it doesn't mean that the mother will not sleep at night. So it is very, very important to tell the mother that she can express her milk night around 10 or 11 and let her sleep for 5 hours. Then she can come in the morning. So the main thing is that frequency should not be too much, that we are calling mother every 2 hourly, and it should not be, delay should not be more than 5 hours. Because then there will be no stimulus. As we say that there should be complete emptying of the breast, and more we empty the breast, more it will be filled. But on the same time, we should look after the sleep of the mother, which is also very, very important for mother to get adequate sleep as well as adequate nutrition. So for early expression is adequate if she is getting, baby is getting less milk, and then slowly the mother will learn. You just advise them and then they will learn according to the need of the baby. If she has expressed the milk and it is too much for the milk baby, then also if she feels that her breasts are filled, she can express her milk.
Thank you, Meena. So I think Meena is bringing a very important point that while we are asking mother to contribute for giving her own milk, we should also keep in mind that she gets adequate rest. And suppose your baby also requires KMC and the mother has to do KMC also and express also, it will become too much. So you need to involve the other family member for doing kangaroo mother care so that mother has some adequate time for taking rest in between, and she must have a good sleep. Unless the mother is going to sleep also, she will be under stress, anxiety, and her milk output is going to decrease. So I think Meena Joshi is bringing a very important point for how do you involve a mother for expression of milk and giving her adequate time for rest if she has to get involved into the other activities. My second question goes to Cecilia. The question is, can you put your video on? We wanted to see you also.
Yeah.
So question for you is, what is the role of giving domperidone and perinom to a mother for increasing milk output? Over to you.
Actually, domperidone and this has been as antagonist to the prostaglandin. So, but it has been proved that it is not essential. It doesn't have a role. Only psychological support, adequate nutrition, and proper counseling will help the mother to breastfeed her baby. And every mother has is tailor-made milk for her baby, which will be enough. So, counseling and support is much essential than domperidone administration.
So the evidence says with the studies which are randomized controlled trial that these drugs work like a placebo. So there is not enough evidence to show that they will increase the milk output. So there are multiple studies on that. So I would agree with what Cecilia is saying, that it is counseling, support, talking that will make and taking care that she takes adequate nutrition and fluids and sleep, that is going to make sure that she will have more amount of milk. So my next question goes to Bobby. Bobby, the question to you is, if a baby is sick, we give minimal enteral nutrition, 10 to 15 ml still we give through the tube feed. What is the advantage of giving minimal enteral nutrition? And whatever you will say, Shrishti will add to it. Please tell us, Bobby, what is the advantage of giving minimal?
While keeping the protein long, it affects the if men, it will help in the growth of the gut bacteria. That is going to help the baby.
Shrishti, you want to add? What are the advantages of giving minimal enteral nutrition? In one of the slides. Is she logged in? Shrishti? So,
Yes, sir, I am.
please.
In the minimal enteral nutrition, what happens is if we are prolonged withholding the feeds, it can damage the gut. It can result in gut atrophy. So this minimal enteral nutrition basically helps to prime the gut, and it helps to improve the gut growth, motility, and the babies who have been started on minimal enteral nutrition are able to have better weight gain, and they are able to attain the full feeds earlier along with a decreased hospital stay.
So the minimal enteral nutrition also promotes many of the gastric enzymes and the enzymes from pancreas. And what people have shown is if you give minimal enteral nutrition, the atrophy of the gut endothelium also will be delayed. So it is always better to give minimal enteral nutrition. And people have also said that it increases the enterohepatic circulation, even the risk of jaundice will be. So minimal enteral nutrition, always give 10 to 15 ml per kg of mother's own milk. It should not be formula. It has to be mother's own milk in minimal enteral nutrition. So now my next question goes to Pratima. Pratima has been running the entire platform for all of you. And my question is, I learned from Shrishti that we have to continue giving iron and vitamin D till 1 year of age in preterm babies. I am asking you, at what age and what dose we should give iron and vitamin D? Pratima.
Asked on this in the group also.
Just
Yes, sir.
summarize.
Iron and vitamin D should be started when the baby has reached significant amount of oral feed. Normally in the units, 100 ml per kg per day is the cutoff taken where we add the supplement. Iron should be added at 2 weeks of age in very low birth weight infant, not before 2 weeks of age. Why? Because antioxidant and oxidation fighting properties are less in the first 2 weeks. So the WHO recommendation says start iron at 2 weeks of age in very low birth weight neonates. Vitamin D also, if the baby is on significant oral feeds, the dose for vitamin D is 400 international units per day for term babies, and vitamin D in the dose of 800 international units per day for very low birth weight infants, which is less than 1500 grams. Iron dose, classically we start at 2 to 3 milligram per kg per day. However, for preterms and extreme preterms, the dose may be increased till 4 to 5 milligram per kg per day also.
Thank you, Pratima, for clarifying this question. This was discussed in your forum also. So, Shrishti, one more question, because you run a human breast milk bank. I know it's a huge investment. It is very difficult to run a human breast milk bank, but you are doing a good work, at least for few hospitals which are connected to your institution for getting the milk. So, tell me, Shrishti, are you around? नहीं तो क्वेश्चन और किसी के पास जाएगा. Shrishti? Okay, now my question is to then Meena Joshi. Meena, tell me, in a preterm baby, what are the cues that this baby is ready to take the feed? How do you, as a staff nurse, identify कि यार ये बच्चा भूखा है, अब इसको दूध देना है? कैसे पता लगता है? मीना?
So the baby have sucking burst. So baby will shows like he will take out his tongue and start sucking. So this gives like the baby is active and sucking. He has he will start sucking his OG tube even when the baby is in OG tube. So we can sometimes see the baby sucking OG tube. In between, baby will have sucking burst and active, and baby sucks his finger sometime.
You have to identify few cues which will give you an idea that this baby is hungry, it is a feed time, like it is adults also. If you are hungry, what do? You keep on going to the kitchen to look around कि क्या बना हुआ है, या फ्रिज खोलते हो बाहर जाके क्योंकि भूख लग गई है. वैसे ही बच्चे को भी वो हाथ पैर चलाने लगेगा, वो जीभ चलाने लगेगा, ट्यूब है तो उसको चूसने लगेगा. तो ये these are like subtle signs which the nurses need to identify. But while your baby is sick, he is on tube feeding, you have to follow the regime every 2 hourly or 3 hourly whenever the feed is given. The baby's tummy is going to be full with that. And the sick babies normally may not show you the cues, but that also has to be ensured that we have to give feed because fluids are required for the baby. We need to maintain his blood sugar also. Some electrolytes also has to get to the gut. So make sure the feeding is not missed in a sick baby who may not show you the cues. But the cues will be there for a baby who is going to be alert, active, and moving around, that telling the mom or even the staff nurse who is like also a mom for the baby in the NICU that this baby needs now feeding, and the mother has to be called. She was doing kangaroo mother care and then giving with the help of a spoon. So mother has to come and express the milk and to be given to the baby. Now, Shristi, question to you is that if you have given donor's mother milk to the baby, are you around, Shristi? नहीं है वो वहां पे, तो मैं ही आंसर कर देता हूँ. किसी ने क्वेश्चन पूछा हुआ है चैट बॉक्स में, if the baby is on donor's mother milk, how do you wean that donor's mother milk? There is no weaning in donor mother's milk. जब तक मिलता रहेगा वो सेफ है डोनर मदर मिल्क, तब तक दोगे. नहीं तो अब दूसरा मिल्क देना पड़ेगा बच्चे को. जब वो आना ही बंद हो गया जहां से आप ला रहे थे बैंक से या कहीं से, जो मिल्क था डोनर मिल्क, अगर वो आना ही बंद हो गया, then you have to resort to mother's own milk which has to be given to the baby. We should try always to avoid giving formula milk to the baby. And you can engage the mother if the mother was earlier sick, she was not able to donate the milk. But if you engage the mother and mother meets the baby and she knows how the baby is improving, she will get motivated and she will express the milk for the baby. And we know even if the mother is not expressed milk for 10 days, 14 days, still the relactation can be established in that mother also. Keep that in mind. So we have to promote giving mother's own milk. माँ का अब अरे हमने बात ही कर दी तुम्हारे बारे में. माँ का दूध बच्चे के लिए इसलिए बहुत इंपॉर्टेंट है कि उसमें ऐसे ऐसे न्यूट्रिएंट होते हैं जो कि ब्रेन जब बच्चे का डेवलप हो रहा था उसके न्यूरॉन में माइलिनेशन में हेल्प करते हैं, ब्रेन ग्रोथ में हेल्प करते हैं. So it is very important that mother's own milk should be given to the baby. And we also know माँ का दूध पिलाने की वजह से बच्चे को NEC और इन्फेक्शन का रेट भी कम हो जाएगा. So Shristi, we covered, there were 2 questions for you. We were not able to connect to you. So I would urge all the participants who are in the app still on the e-course, if you have more questions to be asked for nutrition, kindly address to the faculty member in the same Telegram app. In addition to, you are learning in this week developmental supportive care. So address your question on developmental supportive care also, and few questions on even nutrition can be addressed during this week. And also kindly make sure all of you take your quiz, which is of week 3, because we know nearly more than 2,500 of you have taken the quiz. Your scores are with us. So we want more people to take the quiz, which is there on the Google sheet, or it is there in the bot app, which is there. Thank you once again, Meena Joshi, Cecilia, Bobby, and Shristi, and Lallan, Pratima, Dr. Annu, and Puneet working behind to make sure. And Prashant, we have another technical person who supports us for making our background and everything. So thank you, Prashant, for helping us today again for the weekly session. We will connect to you again next week. Thank you so much. Thank you.
Can we take one
क्या
screenshot?
अच्छा, एक स्क्रीनशॉट सब अपना ऑन करो. ये लल्लन जो है वेबसाइट में डालेगा, इसको वेबसाइट में डालना है. इनका हमें सारे इंडिया को बताना होता है कि हम ये हो रही है टीचिंग लर्निंग. तो
Put on your video, please, सब लोग.
So बॉबी वर्गीस, सिसिलिया एंड मीना जोशी अपना वीडियो ऑन करिएगा, जिससे हम स्क्रीनशॉट ले सकें. लल्लन को लेना है, वेबसाइट में जाएगा ये आज ही.
हाँ, मीना जोशी आ गई. सृष्टि आपका नहीं आया.
सृष्टि ने तो पूरा वो टोपी वोपी पहनी हुई है, पीपी, उसके साथ ही ले लो फोटोज की.
अनु, डॉक्टर अनु. बॉबी,
बॉबी ऑन करो अपना कैमरा. ऑन
अरे
है.
ठीक है, ले लिया. थैंक यू सो मच.
Thank you so much. Thank you everyone for connecting today, and it is wonderful. And we will see you next week with next week faculty. And thank you this week's faculty. We missed Ravi Sachan. We missed Levis. They had their classes. They were busy somewhere. But it was wonderful having all of them together for the entire week. Thank you, Pratima, Dr. Anu. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.